Hello, and welcome to GAPNA Chat, an official podcast of the Gerontological Advanced Practice Nurses Association. GAPNA Chat provides interviews and discussions with GAPNA leaders and members of the gerontological healthcare community, and will focus on advocacy, policy, education, professional development, research, and clinical care for older adults. Before we get started, if you are an advanced practice nurse caring for older adults and want to further your career, GAPNA encourages you to sit for the Gerontological Specialist Certified exam and earn your GSC credential. This expert certification distinguishes APRNs with the knowledge and experience to manage the complex health needs of older adults. Visit gerocert.org to learn more. In this episode, Dr. Cassandra Vonnes, a gerontological nurse practitioner and member of the GAPNA Communication Team, talks with Dr. Jody White, the Director of Care Delivery Innovation for Hospital at Home at the University of Alabama Birmingham. Dr. White discusses the trends and motivators impacting strategies that support teamwork, mindset, and care delivery for gerontological patients managed outside of a hospital setting. In addition, technological advances supporting and elevating hospital-at-home remote patient monitoring and the rise of patient communication devices, including wearable technologies for an aging patient population, are highlighted. We are pleased to present Dr. Vonnes' interview with Dr. White.
So, welcome to 2023, Series 3 of our GAPNA Chats. And today we have Dr. Jody White. He pursued his MSN in Nursing and Health Systems Administration with a focus in quality and outcomes management. I don't know how you go back from Alabama to Auburn and how that works, but I guess, you keep everybody happy in Alabama. And then you ultimately received your DNP in Healthcare Leadership at UAB in 2010. Currently, Dr. White is serving as the Director of Care Delivery Innovation for UAB Medicine. In this role, Dr. White is ushering in a new care delivery model called Hospital at Home for UAB Medicine. Thank you for joining us today, Dr. White.
Thank you for having me. Yes.
So tell me what a young undergraduate Jody, 25 years ago, would have thought about where he is today.
Yes, when I reflect back on where I started and to where I am now, I'm so proud of that, as, I think a lot of nurses are when they look back over their career. But for me, the interesting piece is that I didn't pursue nursing originally as an undergraduate. I had started working and being influenced by certain things, but there was a particular moment in my high school years, it was actually my junior year, where at the Sunday Easter dinner table, when you're projecting and talking about what your future is going to be, what you want to do, I had said, I want to, become a nurse. And I distinctly remember my grandmother and great aunt just simply very casually saying, boys really shouldn't be nurses. And that was their mindset at that time. And so I guess I kind of took that to heart. And then later on, pursued other degrees, but still had that calling to be a nurse. And so when I look back and realize the reflection, and it was real easy to become a nurse. Like nobody really said, no, don't do this. It was just a thought in their head and their mindset at that time. So to where I am now, I am so thankful for that journey and for where I am, for all the growth and development that I've done personally as in myself and professionally, to step forward, to become a nurse leader. So it's been really good to me.
And you talk like a nurse. You don't talk like a bean counter. So, so we're very fortunate to have you in our profession. And even before you went down this nursing route, you were involved as the financial officer in the home care business. How did your experiences help define your nursing role now, particularly in home services?
Absolutely. So I had a very great opportunity when I finished up my original undergraduate to be able to align with a home health, hospice, home infusion organization and really learned a lot about healthcare in that role. And this was before 2000. It was actually before Y2K when we were all scared that all the computers were going to crash. And so I had an opportunity to help bring in a new computer system for billing, revenue cycle management, expense management, and all of those things. And absolutely loved what I was doing, preparing reports and pro formas and managing payroll for the organization and just keeping things running in the background. But yet, when I interacted with those hospice and those home health nurses and really understood the business and the opportunities that they had to go into patients' homes and to, care for them, that original calling that I had to be a nurse, I mean, it was still there. And, maybe I was a little bit jealous of the work that they were doing compared to that bean counting that I was doing. And they were able to get out and come back with wonderful stories about patients and families and situations and just the genuineness of the work that they were able to do, to bring mercy and grace and relief to families. And that calling in me after I did that role for almost 4 years, I just said to my organization, I was like, I really want to be a nurse. And, I wanted like to take educational leave to go back and do this nursing thing. And there was, of course, a nursing shortage then. And they said, well, absolutely, let's get you set up. And so they gave me a great opportunity to step away and go and pursue my nursing career or my nursing degree, and then come back to the organization and continue to serve as a nurse. So, that foundation of understanding that finance piece and now the clinical piece and what things actually mean and patient care has really grounded me. And I'm so appreciative for that time in my life and that opportunity.
That's such a holistic approach to finance. I wish more of our business leadership, had that heart. Now, one of the things that you did when you were working on your DNP, a project that you adopted, and I'm really interested in how the AHRQ team steps or strategies and tools to enhance performance and patient safety. And for those of us that, had to look up the acronym, works. And I look at many DNP projects, and I'm a mentor for our university, and I'm really intrigued in how that implementation, that innovation spread happens with the ideas. So maybe you can share a little bit and how that has informed your role as the Director of Care Delivery Innovation at UAB.
Absolutely. So when I was pursuing the DNP, one of the burning sense of urgencies that I had, recognizing, the trends and patterns and things that were happening around me was just, there was teamwork happening, but that teamwork was not happening to really the level that I felt that it should. I mean, I felt that there were, everyday, communication issues that, hey, we could do something about that. And, various levels of just nurses and physicians and just the whole interdisciplinary team and how we conducted themselves. And when I started out on the DNP, I looked at several teamwork models and really arrived at team steps because I thought that it was the most comprehensive opportunity at the time to bring something into the organization that could do good. And so was able to do that, had great support from the hospital to do that, and really, demonstrated a great improvement in people's understanding of teamwork, their attitudes towards the use of teamwork, and then the results, that we all recognize that, hey, because we're now talking the same language and we understand we're empowered to speak up or to call a huddle or to debrief after an episode, it made a difference. And so now, as this director for setting up hospital at home, I have that same concern. And that is, this is going to be autonomous team members going into patients' homes. So, what do we need to understand about the team structure that we're working in? People need to understand that and know how we're all connected. They need to know what that mutual support and how we build that mutual trust each day to support each other to go into these homes. And then, of course, just the communication piece of what people need to optimize and the standards around how do we communicate what's happening within these patients' homes. And then I really think one of the most important things that I'm doing is that as I interview staff to come into this model, I want to have an understanding of what their attitudes toward teamwork is, because what's happening with hospital at home or anything in healthcare will not happen unless it is occurring within a good foundation of a teamwork strategy. So that's some of the work and that's some of the mindset that I'm bringing in past work as I set up this care delivery model for UAB medicine to make sure that we incorporate those things.
It's very important to break down those silos. I think we realize that. When we reflect back over the last couple of years, what role were you working in during the second quarter of 2020? And how did the pandemic directly impact your patients and their caregivers?
So I was the nurse manager of a critical care unit, a heart and lung transplant ICU, a 20-bed unit. And so that's exactly, what I was doing. And I had done that for a number of years. So of course, with the pandemic and dealing with transplant patients with ventricular assist devices, we were very much so worried about how the virus was going to influence those patients. And it did influence, of course, those heart and lung transplant patients. And so we had our own subset of patients that we were managing and, taking care of right there in the middle of this particular ICU. And those struggles were the same as any other, hospital across the nation dealing with that. Keeping the team motivated, understanding the day-to-day changes and the supplies that we were getting. And we were well supplied. We didn't have any major issues, just a lot of substitutions, a lot of variations and what we were used to. But then, one of the most frightful things to me was looking around the ICU and realizing that these patients were here with us and there were no family, there was no caregiver support, there was nothing. And that to me was a difficult part of, it's just the nurses, the patients, and me, and of course the doctors. So how did we, manage that and make that right with the patients as best as we possibly could? When was it appropriate to bend those rules during the middle of that to allow, in the most dire of circumstances, families to be reunited? And so that's what I reflect back the most. That gave me the most angst, the most anxiety and worry was, yes, the disease process itself, but there was no families there. So bringing in telehealth that we had never done before. So we turned that in on a dime to bring those iPads, to use personal cell phones so that families could connect over, video with iPhones and things. So that's what I was doing. And I'm so thankful that we have stepped forward from that now and that things appear to be very much better for everyone.
It's something that's going to define our nursing careers, well into the next generation. In November of 2020, the Centers for Medicare and Medicaid Services, or CMS, announced some flexibilities in allowing healthcare services to be provided outside of a hospital setting, in response to this surging COVID-19. This acute care at home model allows patients with certain types of conditions to receive their acute hospital care within the comfort of their own home. Was this in the pipeline, like telehealth, and was it just potentially accelerated by the pandemic?
Yes, absolutely. It was accelerated by the pandemic, and it was definitely in the pipelines prior to the pandemic. And just a short little overview is that, hospital at home for the United States really started with Dr. Bruce Leff at Johns Hopkins in the late 90s, and he was able to organize the hospital at home services for a group of patients and do a nice demonstration project. And then there were other hospitals, health systems in the early 2000s that did the same thing. And in 2010, the CMS, the Innovation Center, the innovation branch of CMS, actually put out grant money. I think it was about $10 million for more hospitals and health systems to adopt this model of care and contribute to the literature base. So between 2010 and 2020, we did have an emerging literature base around certain hospitals, health systems who were establishing this type of care. And then right before the pandemic, with that evidence base that we had, I believe the CMS Physician Advisory Group, who oversees reimbursement, they were really trying to come up with what would be the right payment model for these types of hospital at home services. And I think they struggled a little bit with that, and we're still struggling with what that reimbursement model is. But then CMS asked a really important question of itself that, with in the pandemic, with hospitals needing to still provide services, but it's dangerous to do that now inside your hospital with all these COVID patients. And we know that patients desperately still needed hospital care. So, how could they best do that? And so they did bring together a very nice waiver where hospitals could complete an application and an interview and demonstrate how they could pivot and still extend themselves in a safe manner and bring their traditional services into the patient's home. And so now that we have more hospitals now doing this, just recently in December with the congressional spending package that was passed in December, hospital at home was actually set to expire when the pandemic relief efforts expire. I believe that's on May the 11th of this year now. But Congress did a very important thing for hospital at home. And they said, you know what? This is doing some great things. We're hearing some great things. And so they separated hospital at home from the pandemic relief emergency efforts, and they allowed it to exist now until the end of 2024, with the understanding that we're going to have more programs come on board and provide this type of care. We're going to continue to build that evidence base and then be able to make better decisions in a year or two that, yes, we've done the right things, or here's the adjustments, and hopefully here's what the reimbursement model for hospital at home will look like. So definitely it was in the works. And so very eager to see where we land with this at the end of 2024.
What kind of technological advances have been implemented in this model? I know, I come from a cardiovascular background like you, and know that we've done a lot of monitoring of our heart failure folks in a remote setting. But what other kind of technology have you seen in your program?
Yeah, so there are lots of hospital at home technology that's out there, which is really remote patient monitoring, because remote patient monitoring was really already taking place, prior to the pandemic, that allowed us to continuously monitor or to intermittently monitor certain conditions and issues with patients within their home. So the technology, number one, that's important is that, these hospital at home programs having a clinical care command center that's connected to these patients 24/7. So the technology through tablets that are set up and specially designed so that a patient can press a button on a tablet to automatically connect to a caregiver, a nurse back at the hospital to have questions, bring forth concerns, worsening symptoms, those types of things. And then the technology, those wearable devices, when you think about the various devices that you could wear now that can pick up and trend your oxygenation status back, your heart rate, your activity level back to a clinical command center, the Bluetooth technology that you can put on a blood pressure cuff or step on a scale and have that data transmitted back to a care provider from your home. So that's very much so, a piece that's driving hospital at home is that we can continuously or intermittently monitor patients, look for clinical decline, and then we can marry that up with the actual in-person visits that are coming from the doctors and the nursing staff going into these patients' homes to make hospital at home safe and effective. So there's going to be more technology, I'm sure, that reveals itself as we move along with hospital at home. But right now, the technology looks really promising for this care delivery model.
And that's interesting too, that our smart watches have evolved too as the technology's evolved. The driving forces behind hospital and home models seems to be our aging population and their desire to be cared for within their own homes. This is a perfect role for a gerontologic APRN. How has that role been integrated in your program at UAB?
Absolutely. We at UAB Medicine, we already have a house calls program that we have acute care gerontological nurse practitioners who are going into patients' homes who are homebound and unable to make regular trips back and forth to their providers. And of course, with our nursing unit for the acute care for the elderly, our ACE unit, nurse practitioners working within that model. And so absolutely, we will have gerontological nurse practitioners working within this model of care because nurse practitioners are going to be, one of the most important pieces of pulling this model of care together for us and be one of the most forward-facing aspects of our personalized patient-centered care for these patients. So we have a long history of making sure that those roles are situated properly and that they are able to practice at the top of their scope. So we love to implement and bring in those types of roles, especially to this model of care.
That is really exciting. I am sure that this is a huge patient satisfier. And when I look at our population of interest, as being very vulnerable, hospitals are a dangerous place for the older adult. Are you reporting any outcome data as a result of your model?
Yes. So, what's being reported across the nation? So, the patient-centered or the patient-forward data is that patients who are cared for in this model, that they are less sedentary than they would be when they are confined to our hospital room where they get a bed and a chair. But when patients are at home, they actually move more, they spend less time lying flat, and they're able to be in their own comfortable bed, their own comfortable chair, able to walk out on their patio or what have you to have their morning coffee and continue some of that routine. And that drives, less delirium, the less need for restraint. And it's also driving, a little bit lower length of stay for these patients who are able to heal and recover a little bit easier within their home. And then for the organization, that's driving, less readmissions in these patients because it's really a comprehensive model. And, and let's look at it from this perspective. When we as nurses, do discharge planning and preparations in the traditional setting, and the patient tells us what's going on in that home environment, there's going to be certain things that they don't necessarily tell us, they forget, or things that they underreport. But what happens when the hospital, the acute care gerontological nurse practitioner, and the nurses in this model get into that patient's home, and we really see what's effective, what could be effective for this patient, or what's influencing this patient's continued CHF exacerbations, or contributing to whatever that disease process is, and we're able to offer strategy and recommendation for how to handle those things, then I believe that's what's leading, to the less, readmissions for these patients. And then the other parts of the outcomes are, we need to look at, more about what's really happening with the caregivers who are supporting these patients. And so far that's trending that caregivers do like this model of care because it's less stressful for them to have to go back and forth to the hospitals, find parking, pay for parking, and they can spend more quality time, it'd be a less disruptive for the patient and for the caregiver. And then in healthcare, we're always seeking value now, right? Because we have to be physically responsible and do the right things with our resources. And this model of care is demonstrating, somewhere between a 30 to 38% reduction in cost by being able to care for patients in their home. And that's because there's a lot fewer imaging studies, fewer lab studies, being done for these patients. So patients are getting in this model of care, it seems like exactly what they need. But beyond all of this, we have to realize that the hospital at home model is still young, it's still emerging in the United States. And we are going to need, continued data around this and aggregating that data of what's happening across the nation to really forge forward and to make absolutely certain that we're doing right by the patients as we build the evidence base and the practices around hospital at home. So we'll keep our eyes posted and looking for all that data. But I believe that hospital at home is, one of the biggest game changers in healthcare that we've seen in a long time.
Is the interprofessional care provided in person, like physical therapy, or would the dietitian do a teleconsult with the patient, or is it sort of a hybrid of those?
It's a hybrid of all of those things, but certainly, the nursing care is going into the home of these patients. The therapy needs, the physical therapy is going into the homes of these patients. Services like dietary, a nutritionist, that can certainly be done, via telehealth as it's appropriate. So it truly is a blending of the technology and the hybrid of, in-person, per close visits with these patients.
I'm fascinated to learn more about this. One of the things that concerns me is some of the Medicare replacement plans. Are they on board for this as an alternative to an acute care stay, or have you had some challenges?
So when you say Medicare replacement, I assume you're talking about the Medicare Advantage or the
Advantage, yes.
supplemental plans. Yes. So I think that's a very important piece. And there are clearly across the nation those supplemental plans who are very much so on board, with this type of care and getting that to them. And then I think there's a group who are saying, oh, we're going to sit back and watch this and see what happens. So it's really mixed, I think. But when we all consider, what's right for these patients and doing something new, because everybody is focused on the safety, right? We don't want anything to happen untoward that shouldn't happen. And that's our first obligation, no matter who the stakeholder is. But then, recognizing those things and recognizing that, when you look across the globe, that Canada, the UK, Spain, Australia, that they have been delivering hospital at home care for many, many years before us, and that we have great examples in those countries. And we know that those countries spend less on their healthcare, and they do have some better outcomes to report. That we have to take note of this, and that every stakeholder has to do, the analysis to figure out how this is going to work within the United States.
Thank you. That is something very hopeful that has come out of our situation. So thank you so much, Dr. White, for joining us. Do you have any last thoughts to share before we say goodbye?
I'm so excited about hospital at home. I mean, I'm not going to say that I'm not. I'm also nervous about it. Getting it right, because it's got to fit. Within our geography, it's got to be the right things for our patients. And so that's some of the work that I'm doing now, is building and adjusting plans and assimilating data and information each week. But it's also, I think, it's one of the best things that I've done with those early beginnings that I had at home care and hospice, and to see, us come full circle now with traditional inpatient care going into the homes. So I'm so excited and so happy to be leading this type of effort. And I just hope that everyone will, start to take note of hospital at home, think about what the meaning of it could be for your nursing practice, for your patients, and just really start to think about that. And let's see what we're able to accomplish over the next couple of years with this.
Well, I hope I have an opportunity to hear more about this at our GAPNA meeting in New Orleans. So excited to hear about those outcomes that you'll be able to convince the rest of the payers that this is the right thing for them to do fiscally, but the right thing to do for their patient population. And
Yes.
thank you again so much for joining me. And until next time, take care of yourself and as you continue to take care of others. Thank you, Dr.
Yes.
White.
Thank you so much.
GAPNA Chat is owned and produced by the Gerontological Advanced Practice Nurses Association. All rights reserved. No portion of this podcast may be used without written permission. A practical guide for the gerontological specialist is now available for purchase in the GAPNA store. This text is a handy resource for anyone caring for older adults and is helpful to those preparing to sit for the Gerontological Specialist Certified exam. Visit www.gapna.org to get your copy. Dr. Jody White is the Director of Care Delivery Innovation for Hospital at Home at the University of Alabama Birmingham in Birmingham, Alabama. Hospital at Home will allow patients with certain types of conditions to receive their acute hospital care within the comfort of their own home. Current technological advances with healthcare wearable devices combined with home physician and nurse visits will enable care delivered in the home. Dr. Cassandra Vonnes is the Nurses Improving Care for Health System Elders Niche Coordinator, Geriatric Oncology at the Moffitt Cancer Center in Tampa, Florida. She is a member of the Gerontological Advanced Practice Nurses Association Communication Team and is a host of the GAPNA Chat podcast series. For archived episodes of GAPNA Chat and to learn more about the Gerontological Advanced Practice Nurses Association, visit gapna.org. You can also subscribe to GAPNA Chat everywhere podcasts are found.